A very good morning, everyone. I thank Dr. Fairuz for including me in this wonderful instruction course, and I welcome you all today. So I'll be taking you through the conjunctival lesions and some tips and tricks to diagnose them appropriately and how to tackle them in your practice. So as we have been taught by our mentors, that conjunctival lesions are something which comes with a signature. They're actually there on the surface staring at you, begging for a diagnosis is what Dr. Hanawar always says. So before diving into the wide spectrum, it's important to know where all they can arise from. Here I would like to highlight the importance of an inverted eyelid examination, because upper tarsal conjunctiva is something that often gets missed, and also to know the layers of the conjunctiva histopathologically, and from every layer lesions can arise. Epithelial, we divide them into non-melanocytic and melanocytic, stromal, caruncular, even metastasis can happen, secondary tumors. So as you can see, the list is huge. It can be overwhelming, but as I'll take you through the signatures of the lesions, I think it is important to recognize them so that it can be diagnosed. So definitely it is a wide spectrum of lesion, but there are specific points in history in your clinical examination which at least helps you to have a clinical checklist and to categorize them first into a benign and a malignant lesion. Well, there will be some lesions where you are doubtful about your diagnosis, but at least keep some differentials in your mind so that you can proceed appropriately. Starting off with the simplest one, if something like this comes to the clinic, which is a clear cystic mass, what's happening here is the transillumination. It is mobile, and if I give you a history that it might have occurred spontaneously or following some inflammation or surgery, of course, we all know that it is an inclusion cyst. The diagnosis will be straightforward, and management would either include observation if it is a small one or a surgical excision biopsy. What about lesions like this? This is a gentleman who was seropositive, and if you can see, it is a fleshy red mass with frond-like or finger-like projections. The vessels around it are obviously would make me keep a differential of OSSN in mind. In fact, in his other eye, he was diagnosed to have an OSSN, but on histopathological examination, this came out as papilloma. Papillomas are known to occur in immunocompromised status, and there have an association with human papilloma virus, specifically 6, 11, 16, and 18. After the diagnosis, the treatment can be either observation or when excised, it should be a no-touch technique with cryotherapy at the base to help prevent the recurrences. Topical treatment is also known. What about lesion like this? It is limbal. There is some thickening happening in the conjunctiva there. What is to note is these specks, which are the specks of keratin. Definitely doesn't look very angry or fiery looking, and it is actinic keratosis, which can happen because of too much of UV light exposure. And the treatment can be either close observation, serial pictures that we can keep so that we know that it is not increasing, or surgical excision with cryotherapy. So what is happening here is a dysplasia of the conjunctiva, and it is like a spectrum. It can be mild, moderate, severe. It can be carcinoma in situ or invasive squamous cell carcinoma, which are the squamous epithelial lesions of the ocular surface, which is an umbrella term which comes under ocular surface squamous neoplasia. It is the most common non-pigmented tumor of the ocular surface, and it is most commonly encountered, and hence it should not be overlooked, it should not be misdiagnosed, and hence not mismanaged. It occurs around the limbal area, and it has many risk factors associated, mostly unilateral, but in cases like xeroderma pigmentosum or immunocompromised status, it can be bilateral also. What is to be looked for is a fleshy or a nodular mass. It may be even sessile. The surface keratin is very important, which stains positive with rose Bengal staining, the intrinsic blood vessels, and the dilated feeder vessels. Of course, not to miss is the scleral fixity of the lesion. Take a cotton bud and actually move the lesion to see if it is affixed to the underlying sclera, showing the extent of it. And of course, not to miss also is the upper tarsal conjunctival examination, where a lesion might be sitting, and also to check the lymph nodes, because it is this invasive squamous cell carcinoma is a malignant variant. So we have been taught this, that if we have a combination of keratin being on the surface, vascular pattern, the typical vascular pattern, the intrinsic and the feeder vessels, and rose Bengal staining, the sensitivity and specificity of a clinical examination is very high. What about lesion like like this. Very subtle. Here it is stained with rose bengal, so we can see the pinkish hue. But the wavy, translucent corneal lesion, when we do an anterior segment OCT, you can see the hyperreflective epithelium here. So this is also a variant of OSSN, predominantly corneal OSSN. Another thing I would like to highlight is the clinical documentation. Well, you see a nodular lesion sitting there, but what about the thickening of the conjunctiva happening around it? This is your extent of the lesion, beyond which you should go for the excision of this lesion. Not just the apparent looking lesion, but the thickening of the conjunctiva, which can be picked up in slit lamp examination. Go 4 millimeters beyond this lesion when you're excising this lesion. Always good to have a photograph or your clinical picture in the operation theater so that it guides you better. What about lesion like these? Less keratin, but this is like a histopathological variant which are very aggressive. Mucoepidermoid carcinoma, adenoid, SCC are some. Morphological variants are many. It can be leukoplakic, gelatinous, papillary, even pigmented OSSN is known. And hence simulating lesions are also many. So keep all these things in mind and pick up those subtle points in your clinical examination to diagnose this better. Imaging in OSSN, when anterior segment OCT shows a very typical snouty appearance. The cutoff is 120 micron. Anything above that is abnormal, to keep that in mind. Too much of keratin might give back scattering, so lesion and the depth might not be seen in such cases. Of course, a very extensive lesion might require further imaging like CT scan, which shows how further spread or intraocular spread or orbital spread it has. This slide I've just put for the AJCC TNM classification that you should keep in mind. And the management options are many, but it all depends on whether the lesion is localized, diffuse or invasive, whether you have to go for a surgical excision, or we have magic drugs like interferon in our hand, plaque brachytherapy, and even exenteration or enucleation, which might have to be resorted to. So surgical excision is quick, it is diagnostic and therapeutic, and it is in fact the gold standard. Just a quick video here. We go 4 millimeters and take a wide margin beyond the clinically apparent lesion. A no-touch technique is what has been described. Alcohol keratoepithelectomy is something that needs to be done for the corneal side of the lesion. Limbal sclerectomy has to be done. Cryotherapy is a double freeze-thaw cryotherapy for the resected conjunctival edge and the base of the lesion, and you can actually do the ocular surface reconstruction with amniotic membrane graft. This Dr. Shruti will definitely agree with me. When you excise the lesion, it is so important to place it properly on the Wortmann filter paper, unroll the margin, and basically if you have to take extra margins, they need to be labeled so that the histopathology report specifically highlights if any positive margins are there, so that it can be dealt with further with the management that we are going for. And the histopathology report should include a comment on the base of the lesion and the margin of lesion, and not just the diagnosis that it was an OSSN. So the newly emerging treatment options are chemotherapeutic, that is mitomycin C or 5-fluorouracil, or immunotherapy in the form of interferon alpha 2b, or cidofovir has also been known. I've just put up this slide to show the adverse effect. I would just like to highlight that interferon is available in India. We are very lucky in that resort, and it is the gentlest of the drugs that you can use for the ocular surface, and it works really well. It is non-invasive. Of course, there will be scarless healing, but definitely we don't have a histopathological diagnosis when we use such drugs in our hand. So our diagnosis has to be very clear, and we should have certain indications where we are going to use these drops. It can be either given topically, or there can be an injection of the interferon alpha 2b. So this drug acts like an immunotherapy, where it can totally take care of the lesion. Immunoreduction in a big lesion like this, where we have multiple layers of the lesion. So when we use these drops, what happens is the surrounding dysplasia actually goes off, and what we are left with is a smaller lesion which can be dealt with surgically. And also immunomodulation in cases like these, they can be, especially like interferon, can be kept on once daily use indefinitely. Many papers exist which shows that surgical versus use of interferon alpha, which has been proven to be similar, and 5-FU and interferon, but definitely interferon is more gentler on the surface. What is important is to know when not to use this therapy. Definitely basically when you're unsure of the depth of the extension, non-compliant patient, and when the diagnosis is in doubt. And interferon works wonderfully well. We give it in cycles, monthly cycles, and reconstituted drops. Intralesional with topical is also something that works really well, as you can see in the patient here. Another thing is if we can also switch the therapy if like this patient had undergone 6 cycles of interferon, but there was a certain corneal lesion which was just not going, and when we switched him to 5-FU, it worked really well. This is a case I had seen in my fellowship with Dr. Navasa. So and when the lesion is very extensive, and we can even resort to enucleation and exenteration and rehabilitate these patients appropriately. Definitely, if the base turns out to be positive, secondary plaque brachytherapy is something that we need to give additionally, so that the base positivity is taken care of. Local recurrence, definitely 20 to 40% has been reported, but if we go protocol wise, the recurrence rate comes down to less than 5%. Going on to these two lesions, I have just put them here so that you can have them in your mind, because they look very much like OSSN. In fact, they simulate SCC, but these are pseudoepitheliomatous hyperplasia and hereditary benign intraepithelial disc keratosis that you should keep in mind and proceed appropriately. What about lesions like these? Unilateral blepharoconjunctivitis should always alarm you. And especially if you see so much of keratin being there, definitely this is diffuse OSSN, as Dr. Seema had also shown. Pagetoid spread of SGC is also common, and it should be dealt with appropriately. Coming on to the pigmented lesions, lesions like these, unilateral, they are flat, no cysts are seen. This is nothing but primary acquired melanosis. They can be present with atypia when it becomes slightly dangerous, and hence would warrant further treatment. So the progression to melanoma is something which is concerning. With atypia, it is known to be 13%. What is important is to know the clock hours of these lesions. So the more the clock hours, and it has been shown that the relative risk of increasing the danger of PAM would be 1.7 times. So when to treat PAM? Basically, it can be simply observed too, and excision is warranted in these situations with cryotherapy and excision with the excision edge cryotherapy if it is more than 3 clock hours. What about lesions like this? If I give you a history, most common melanocytic tumor of the conjunctiva, it clinically appears generally in the first or the second decade of life. It is conjunctival nevus. What I would want to highlight is the characteristic clear cysts that exist in the lesions here. Can I just take one more minute? Yes, sure. And these are known to be associated with feeder vessels in 64% of the cases. So when do you treat? When either the patient is cosmetically concerned about the lesion, or there's a specific increase in the size during puberty or hormonal changes, and it can be either serial observation or excision biopsy. This is just a quick video showing basically the excision of the nevus. This was a nevus in a 11-year-old boy, a 13-year-old boy, and we just went on with the total excision of the nevus and direct closure post the excision. Of course, a definitive diagnosis is achieved after we send it for the histopathological examination. So quick surgery and yeah, a very good cosmetic outcome. And what about lesions like this? You also have to keep in mind that the nevus can be with very less pigment or apigmented also, but the cysts and are something that you should be keeping in mind clinically. This was a case which looked like a melanoma, but not a typical feature of melanoma. There's no very angry looking feeder vessels here. So keeping that thing in mind, we did go ahead with the excision of this, and this came out to be a giant balloon cystic nevus. This Dr. Seema had already covered, nevus of Ota, something to keep in mind. It is not conjunctival, but something like a scleral pigment, but the importance is that it can be associated with uval pigments. Fleshy, nodular, deeply pigmented lesion like this, of course, this is melanoma, and it can arise from PAM or pre-existing nevus or de novo. What is important is to know the thickness, which is the most important prognostic factor here. And very, very alarming thing about melanoma is the regional metastasis and the systemic metastasis. and hence it has to be dealt with properly. Even the overall mortality seen in 10 years and 15 years is quite high. Sentinel lymph node biopsy is definitely indicated. Small lesions like this, florid, very red mass with a prior history of either inflammation, surgery, or non-surgical trauma can be pyogenic granuloma. Don't get fooled because it can appear even like this. This was a lady who presented with a big mass like this, but it was pedunculated and there was florid vessels here. She underwent excision. Definitely we kept keratoacanthoma in mind, so we did give cryotherapy at the base, but it turned out to be pyogenic granuloma. Venolymphatic malformations can be easily dealt with drugs like bleomycin, and lesions like this which might appear something like a lymphoma, but what I want to highlight is definitely look at the colors of the lesion. So you have a yellow hue here, which is nothing but amyloidosis, and what has to be very carefully looked in such lesions is the yellow hue, and they can definitely present in multiple morphological forms. So just pick up the clinical clues here and do a thorough examination. Other lesions are like newly described lesions are COST, which appear like a translucent dome-shaped lesions. Limbal dermoids have a systemic association. Look for hair in dermolipoma, which can clinch the diagnosis, and they can be easily debulked and excised. And fat prolapse is something in elderly because they can mimic lymphoma, so keep the clinical clues in mind and appropriately. This, I've just put it here, salmon color that you should not miss. Feeder vessels, it is nothing but a conjunctival lymphoma. It is also a spectrum from benign reactive lymphoid hyperplasia to malignant lymphoma. It can be multifocal, so this is something that again you should keep in mind. And systemic examination of the patient is so important because it has a chance of association of systemic lymphoma, and it can be treated appropriately. Caruncle has a lot of basically it has sebaceous glands, it has skin, so many layers are there which can give rise to multiple lesions and need to be dealt with appropriately. So I just would want to highlight the spectrum is very wide, but a clinical diagnosis can be made appropriately. Surgery mostly is the mainstay. In most of these cases, observation is there, and we should be knowing about the targeted therapy, immunotherapy, which has promising results in such cases. Thank you so much. I'm so sorry for extending the time, but wide spectrum.
Thank you, Dr. Shaifali, for that excellent overview of conjunctival